Assalamu alaikum. Good evening, everybody. I would like to welcome you all on behalf of the GAED, Gulf Association of Endocrinology and Diabetes, to tonight's webinar titled A Novel Approach to Cardiorenal Disorders in Diabetes. I'm Dr. Mohammed Bashir. I'm a senior endocrine consultant in Hamad Medical Corporation in Qatar. First of all, I would like again to welcome you to the webinar, and I would like to ask you all to join the largest society in the region, Gulf Association of Endocrinology and Diabetes, the GAED. We would love that everybody will be able to join this growing community. If you'd like to do so, please scan the QR code and join the endocrine community in the Gulf region. And we also would like to invite you to follow our activities on the social media. We're running multiple webinars and multiple activities and campaigns over the social media as well. And your support will be really critical for the success of this society. Today, webinar is actually sponsored by Bayer, and it is CME accredited. And everybody registered will receive the CME certificate on their emails in the coming few days, inshallah. So without further ado, the webinar is going to consist of 3 talks presented by Dr. Ala Bashir, Dr. Anas Yusuf Al-Yusuf, and Dr. Ahmed Abdullah. And during the webinar, if you have any questions, down at the bottom bar, you will find an area where you can actually post your questions. And at the end of the webinar, we will have about 20 to 25 minutes discussion to go through all the questions. So our first speaker today is Dr. Ala Bashir. Dr. Ala is a consultant endocrinologist and internist in Dubai Hospital and Dubai Academic Health Corporation. Dr. Ala is a professor of medicine in Mohammed bin Rashid University, and he has authored and co-authored more than 80 public original papers and multiple chapters. Dr. Ala is going to talk to us today about an overview of ADA standards of care in cardiorenal disorders. Ala, the stage is yours.
Thank you very much, Dr. Muhammad. It gives me a great pleasure to be with you all today. And I've been given a task to talk today about the ADA guidelines. And I'm going to focus basically about the chronic kidney disease and risk management, the chapter in standards of care in diabetes in 2026 by the ADA. And basically to start the talk, I'm just going to tell you that this chapter has contained around 19 recommendations. 10 of them were grade A and the rest were mostly B, and there is a couple of recommendations grade C. It covered around 14 topic areas within the diabetic kidney disease. And to start with, would like just to make sure that we agree on the definition of diabetic kidney disease, and it's defined as an excessive proteinuria or albuminuria more than 30 milligram per gram, or a progressive decline in kidney function below 60 ml per minute. And we know that we used to have to define diabetes as diabetic nephropathy, but now we know that there is a different category in patients with diabetes who do not present with albuminuria, and they're defined as non-albuminuric diabetic kidney disease. So diabetic kidney disease involves both diabetic nephropathy with classic albuminuria and the non-albuminuric kidney disease. The difference is simple between the two types. The albuminuric is the classical form, whereas where we see albumin excretion more than 30, and it's if we go back to the early knowledge about it, we know that it's because of glomerulosclerosis and the typical Kimmel-Stein-Wilson lesions and basement membrane enlargement, and it's basically due to microangiopathy, and it has a close relation to retinopathy. So with albuminuria, it's closely related to presence of retinopathy, and it's more common in males, and it has a correlation with A1C. The higher A1C, the more uncontrolled diabetes, the likely patients will present with diabetic nephropathy, where the non-albuminuric form is another form that presents with only a reduction in EGFR without proteinuria, angiopathy rather than micro, and it has no relation to diabetic retinopathy. It's due to tubular defects rather than glomerular defects, and it's more common in females, and it has no relation to A1C. Having said that, we know now diabetic kidney disease actually constitute around 20 to 40% of around 20 to 40% of patients with diabetes develop ultimately chronic kidney disease. And patients with type 1, it usually develops after 5 years of diagnosis, so 5 to 15 years. And it's usually in patients with type 1 related to diabetic retinopathy, where in patients with type 2 diabetes, diabetic kidney disease usually might be present at the time of diagnosis. And that's why the recommendation is to screen earlier. So this is the first point. It's very common, 20 to 40% in patients with diabetes, and it's the leading cause of kidney failure worldwide. More important, it's a cardiovascular risk amplifier. And we know that there is a close relation between presence of proteinuria and the increased cardiovascular risk. So it's a marker of cardiovascular risk in patients with diabetes. And more important, even acute kidney disease is more common in patients with diabetes than non-diabetic patients. There was a study in 2020 that has shown that patients with diabetes have 5 times the risk of developing acute kidney disease compared to non-diabetic individuals. So for that reason, the guidelines generally recommends annual screening for all patients with diabetes with both albumin excretion, urinary albumin creatinine ratio, and EGFR. The screening should start basically at the time of diagnosis for patients with type 2 and 5 years after diagnosis for patients with type 1. The recommendation on the left side, the recommendation B, that's from the American Diabetes Association, while on the right side, the stick note is the recommendation of the Emirates Diabetes and Endocrine Society, or UAE guidelines for management of diabetic kidney disease. And both actually agree on the fact that in patients with type 1, it has to be done after 5 years, and in patients with type 2, it has to be started screening at the time of diagnosis. Now, how should we measure the EGFR? Should we measure it by the cystatin C or the MDRD, or should we measure it by the CKD EPI formula? Basically, the agreement since 2021 is to use the CKD API creatinine equation to measure the EGFR in those patients, but cystatin might be helpful as well, the formula with incorporation of cystatin. And it's basically important in patients with altered body, when we need to calculate with altered body surface area. For example, people with amputation, frail people with low muscle mass, and in those with liver disease. And we have to remember whenever we use the cystatin C that it can be affected by many other factors other than kidney factors, including inflammation, age, sex, thyroid function. People with thyrotoxicosis might have an abnormal cystatin C values. So basically, the agreement is to use the CKD API, but in certain situations, we might need to use other formulas. Now, how to screen, as we mentioned earlier, that we need to use both albumin creatinine ratio and eGFR. And we need to screen as well for cardiovascular complications in patients with type 2. And this is a recommendation by the UAE guidelines. What we added as well when we monitor for albumin creatinine ratio, the UAE guideline recommends as well at the same time do a urine routine. If you have a positive urinary albumin creatinine ratio, you need to look at the urine routine for any active sediment, whether presence of cast or RBCs that might indicate a non-diabetic cause for CKD, and those patients might need to be referred earlier to the nephrologist for probably a kidney biopsy or further investigations to know the underlying cause. So monitoring, the recommendation regarding monitoring that patients with established CKD should be monitored 1 to 4 times based on their level of CKD. So, an earlier levels of CKD, for example, level 1, 2, level 3, probably they need to do it maybe once, twice a year. But when we go down to stage 4 and 5, the frequency of monitoring should be more frequent. And we know this is the heat map of the KDOQI guidelines, where we monitor or grade patients based on 2 factors. We measure the eGFR and the albumin excretion. So based on the eGFR, we decide whether patients are in stage 1, stage 2, stage 3, and stage 4 and 5. And because albumin excretion at any level of eGFR adds to the cardiovascular risk, hence we have to add as well in the categorization of patients the A1, A2, and A3. Where A1 is considered moderately increased, and between 30 to 299, which is previously called microalbuminuria, is A2, and if it is above 300, then it's A3. So we define patients, we call it grade stage 1 A2, for example, or stage 2 A3. So we have to put the two categorization, albumin and eGFR, to exactly understand the risk level of this patient. So once we do it, we need to know which patient should we manage at primary care level and which patient we should refer to the nephrologist. And these are the features that probably make you think of referring a patient to a nephrologist. For example, if diabetic kidney disease or nephropathy developed in someone with type 1, less than 5 years duration, and in absence of retinopathy. So that's unlikely to be diabetic kidney disease, and you need to refer the patient to the nephrologist. As I mentioned earlier, if there is an active sediment, whether RBCs or cellular casts, those are unlikely to be related to diabetic kidney disease. And in patients who are chronically well-managed blood glucose, and then they develop diabetic or nephropathy, then they need to be referred. And if the eGFR is rapidly declining, if I've seen a patient today, his eGFR is around, let's say 75, and then I've seen him in 3 months time and I found it to be 60. So 15 ml drop in a short period of time, then this patient, if there is no acute injury to the kidney, use of certain medications that probably reduce the eGFR, they need to be seen by the nephrologist to make sure what is it exactly. And if the albumin excretion is rapidly increasing. You've seen a patient today, it's 300, you started medications, then you saw it next time and you found it around 500, and then next time 700. So a rapid increase in the albumin excretion is also a red herring that probably you might need to refer this patient earlier to the nephrologist for further evaluation. So in summary, this is the UAE guidelines. It just put the same in different categories. We categorize patients to be referred based on EGFR. And if the EGFR is basically below 45, then the patient has to be referred to the nephrologist. So stage 3B and below, you need to refer to the nephrologist. And if there is a sustained fall in EGFR more than 20% or more than 30% on a starting any treatment, whether SGLT2, ACE inhibitors, ARBs, then those patients has to be referred to the nephrologist for further evaluation. So this is based on EGFR criteria. And based on the albumin excretion and microscopic hematuria, if the albumin excretion, as I mentioned earlier, is more than 300 and is increasing, then you need to refer your patient. And if there are urinary casts, then you need to refer, where the nephrologist is going to do further evaluation to define the cause of diabetic kidney disease or of chronic kidney disease. In patients with persistent potassium abnormalities that might be associated with nephropathy, if you see a persistently hyperkalemic patient, they need to be seen by the nephrologist to decide whether they have diabetic kidney disease, whether they have any other form of let's say renal tubular acidosis type 4, which is very common to see in patients with diabetes. And other reasons to refer to a nephrologist if there is persistent acidosis or anemia, or for evaluation of mineral bone disorder or malnutrition, those needs to be referred. Basically, they usually develop after stage 3B. So the bone or mineral metabolic bone disease abnormalities, the anemia, they all appear after stage 3B and beyond. So basically, if you refer the patient at 45, you probably be referring those patients as well. And this is exactly what I mentioned earlier. This is the follow-up. Monitoring, stage 3, every 6 to 12 months. Stage 4, 3 to 5 months, and stage 5, you might need to see them every 1 to 3 months regularly. And what the nephrologists generally do, they look at volume overload, they need to take history, examine, check their weight, they need to check electrolyte imbalance, specifically the hyperkalemia, they need to look for the metabolic acidosis and serum electrolytes, anemia. It usually develops after stage 3B and beyond, and metabolic bone disease as well. They look at the calcium, phosphorus, PTH, and vitamin D levels. What about the blood pressure management in patients with diabetic kidney disease? So the recommendation says that the blood pressure target in patients with diabetic kidney disease should be less than 130/80. But they mentioned an important point here, that the goal should be less than 120 millimeter mercury in patients with massive or significant proteinuria. Those patients usually benefit from blood pressure reduction more than those with lower levels of EGFR. So why did they come with this recommendation? Because basically they depend on what's called the blood pressure road trial. The blood pressure road trial looked at two different group of patients, and in this trial, it was actually published in 2025, where they compared strict blood pressure control to less than 120 versus standard blood pressure, which is less than 140. And they found that reducing the blood pressure to less than 120 actually reduced the non-fatal stroke, myocardial infarction, heart failure, and cardiovascular death by almost 21%. And that's why if you can achieve less than 120, then that's the goal. But if it is difficult to achieve it where patients develop postural hypotension, then you can go for 130/80. So the recommendation is standard for all patients, a blood pressure less than 130/80. And the stretch in a specific group of people with albuminuria and high cardiovascular risk is to go for less than 120 millimeter mercury. And basically because the blood pressure road trial has shown a reduction in cardiovascular mortality by 21%. And if we look back at the Accord blood pressure trial, it has demonstrated that participants who have underwent strict blood pressure control, that was also because of use of ACE inhibitor associated with up to 30% increase in serum creatinine. That reduction in creatinine was not associated with progressive kidney disease. So a reduction in EGFR with the use of certain medications, specifically the RAS blockers, is not associated with progressive kidney function. And actually, there was a study, and I was talking all the previous points on the systolic blood pressure. There was, again, a recent trial that showed the benefits of systolic blood pressure reduction are seen only in those in whom the diastolic doesn't drop below 70. So we need to go for a drop in systolic blood pressure less than 130, and better in high cardiovascular risk and people with albuminuria to reduce the blood pressure to less than 120, but make sure that you don't drop the diastolic to below 70. That's why the target diastolic blood pressure is 80. So now the use of ACE inhibitors basically in diabetes is, in patients with diabetes, is not for prevention. So we use it in those patients with hypertension or albuminuria, and they are not recommended for patients for primary prevention. So if a patient with diabetes, no albuminuria, no hypertension, there is no recommendation whatsoever to start ACE inhibitors in those patients to prevent the progression of kidney disease, to prevent chronic kidney disease occurrence. And if we look at studies, we don't have any evidence that RAS inhibitors are actually are actually used to prevent the development of chronic kidney disease. The only proven intervention to reduce or to prevent the development of diabetic kidney disease is a good glycemic control and good blood pressure control. And as long as the patient doesn't have high blood pressure, then any antihypertensive in that case would be helpful. But the question is, does any intervention in oral agents, anti-diabetic agents, is helpful in prevention? If RAS are not, would intervention with any other drug, anti-diabetic, whether liraglutide, sitagliptin, glimepiride, or even insulin, is it helpful in reducing, in prevention of diabetic kidney disease? This is a study called GAED study. It was published in 2023. And it looked at almost 5,000 participants. They were either taking liraglutide or sitagliptin or glimepiride or insulin on top of metformin. And they looked basically at glycemic benefits. And as a secondary endpoint, they looked at cardiovascular and renal outcomes. And they found that there is no difference between all these medications, the 4 medications, in prevention of diabetic kidney disease. All those patients at the start, at enrollment, they didn't have evidence of diabetic kidney disease. And when they followed them at 5 years, they found that there is none of these medications actually help in prevention. Of note, and very important note, is that the SGLT2 inhibitors were not basically studied in those patients because at the time of the enrollment, SGLT2 inhibitors were not like standard treatment. What about the glycemic management? And I guess this is the most important part in the management because currently we do have medications that actually reduce the progression, reduce the mortality, and reduce and improve the cardiovascular outcome in those patients. And basically, we'll be talking about the SGLT2 inhibitors. And if you look at the summary of the renal outcome trials of the SGLT2 inhibitors, we have three main trials. The first one is the CREDENCE trial. That was the first one. And it has included, enrolled around 4,500 patients. And the primary outcome was 4D. The primary outcome was a 4D, which is dialysis, decline in eGFR, doubling of serum creatinine, and death from renal disease. In the three trials, this was the primary outcome. And if you look at the three studies, whether CREDENCE, DAPA CKD, or EMPA kidney, they have reduced the primary outcome by almost between 28 to 39%. So a significant reduction in primary outcome. And if we look at the composite renal outcomes, again, it has been reduced in the three trials significantly, as well as cardiovascular death. And an important point here to mention that the level of risk of patients included in these trials were different, where CREDENCE included all patients were diabetic, and all of them had either established cardiovascular disease or very high risk for cardiovascular disease. The DAPA CKD included around 65% patients with diabetes and around 30-something% who are not diabetic, where the EMPA kidney has almost 50% subjects with diabetes and 50% without diabetes. But in addition, in the EMPA kidney, we had around 20% of the participants who did not have albuminuria. And again, in those patients without albuminuria, the SGLT2 inhibitors proved beneficial in reducing renal and cardiovascular outcomes. And this is basically a summary of the hazard ratio reduction in the three trials, where CREDENCE, we've seen a reduction by almost 32%. The hazard ratio for DAPA CKD was 61, that's 39% reduction. And in the EMPA kidney, we had around 28% reduction in major kidney events. What about the GLP-1 and finerenone? The GLP-1, the main study in the GLP-1 was the FLOW trial. And in the FLOW trial, it's a kidney outcome dedicated study using semaglutide. And we could see that there is a 24% reduction in renal outcomes in those patients, the major kidney disease events. It as well reduced the cardiovascular events, and it did slow the CKD progression in those patients. The other medicine, which is, and I'm sure Dr. Ahmed is going to give you full details about it by the end of the presentations, the finerenone, which is a non-steroidal mineralocorticoid. There were three major studies with finerenone, the Fidelio, the Figaro study, as well as the Fidelity, which is a pooled analysis of the renal outcome and cardiovascular outcome. And from the Fidelity analysis, we could see that use of finerenone in patients with type 2 diabetes and albuminuria reduced composite cardiovascular outcomes by 14% and composite kidney outcomes by 23%. Dr. Ahmed is going to tell you the details about how to use finerenone, whether to combine it or not to combine it with other medications, GLP-1 or SGLT2. And because of this basically overwhelming evidence of benefits for the three classes, SGLT2 inhibitors, GLP-1, and non-steroidal mineralocorticoids, the UAE guidelines in 2025 has actually suggested this algorithm for management of diabetic kidney disease. And the algorithm basically, SGLT2 inhibitors are first line plus or minus GLP-1. This is with regard to glycemic control. And then you need to reassess your patient regularly. If they still need further glycemic control, you can add basically metformin, where you need to reduce the dose to have at eGFR of 45, and you need to stop metformin at eGFR of 30. Insulin can be used, DPP-4 inhibitors, sulfonylureas, TZDs, and alpha-glucosidase inhibitors. And the SGLT2 inhibitors should be used on top as well of RAS blockers. Whenever there is diabetic nephropathy, RAS blockers, the standard should be used at maximum tolerated doses, and then you add on other medications. After the use of RAS SGLT2 inhibitors, then non-steroidal mineralocorticoid agonist finerenone should be used, and finerenone should be basically used if the eGFR is above 25. We can use it simultaneously, and you will get to know the evidence later. And we need as well to manage the other risk factors. So we managed diabetes, we managed hypertension with RAS blockers, and we need to consider treating as well with statin therapy, whether statins alone or ezetimibe or even a PCSK9 inhibitor to reach a target. Just the target in lipid management in patients with diabetes is below 55, because any patient with albuminuria or a reduction in eGFR should be considered a very high risk individual, and the target for LDL should be less than 55. This is the ADA recommendation, and this is the holistic approach of the ADA 2026. And it follows the same algorithm, where we start with healthy eating, physical activity, smoking cessation, weight management, and we need to start with RAS blockers at maximally tolerated doses. When it comes to management of glycemia, and here we talk about patients with type 2 diabetes, the green bars, we start with SGLT2 inhibitors as long as the eGFR is above 20, and we don't discontinue the SGLT2 inhibitors until patients start dialysis or they go for transplant. And now there is an overwhelming evidence as well for SGLT2 inhibitors in post-transplant diabetes management. SGLT2 inhibitors should be used with or without GLP-1 semaglutide, which has the highest evidence. And if the patient is still not achieving proteinuria, reduction in albuminuria, then we need to start the mineralocorticoid, non-steroidal mineralocorticoid. And as I mentioned earlier, non-steroidal mineralocorticoids could be used in combination from the start. The blood pressure management after the RAS blockers, we can go for calcium blockers or even diuretics to achieve individualized blood pressure. If the patient had resistant hypertension, we can go for steroidal mineralocorticoids as long as the eGFR is above 45. And for dyslipidemia, we go for moderate to high intensity statin. And if the patient is achieved the target, well and good. If not, you can add ezetimibe, PCSK9 inhibitors, and icosapent ethyl if the triglycerides are above 150. So I leave this slide because Dr. Abdullah is going to discuss it at the end, and this is about the combination of SGLT2 inhibitors and finerenone. So the GLP-1, I think this is an important question. Usually we're being asked, is it safe to start GLP-1 in patients with CKD or later stages of CKD? There is no actually strong evidence for that, but there is a study, a national cohort study of more than 151 subjects, and it found that the use of GLP-1 in stage 5 and dialysis patients actually linked to reduced mortality by 23% and 66% higher transplant wait listing. The only issue with it practically is it is associated with nausea and vomiting, and subjects with diabetic kidney disease or end stage or dialysis patients, usually they do have nausea and vomiting. So it should be used cautiously. You need to up titrate the dose slowly, maybe 0.25 for 2 or 3 months. And then you go for the next dose, which is 0.5 and the higher. The recommendation here is to avoid lixisenatide and exenatide because they're basically cleared by the kidney and they actually accumulate in the blood, increasing the side effects. So my last point here is the use of the management of CKD in pregnancy. We have mentioned a couple of medications that are renal protective and cardioprotective agents, like the RAS blockers, the SGLT2 inhibitors, the GLP-1, finerenone. All these medications cannot be used during pregnancy, and we should actually avoid using these medications during pregnancy. We might use a safer antihypertensive medications like labetalol, methyl-dopa, long-acting nifedipine. These are very effective and they are safe during pregnancy. Again, if there are any features that suggest non-diabetic kidney disease, patients has to be referred immediately to the nephrologist for further workup. So what are the key takeaway messages here? So I just put 8 messages, very simple, straightforward. The first takeaway message is screen your patients annually or more frequent if they have a lower, if they have already established diabetic kidney disease. So screen annually with both UACR and EGFR. Screening should be 5 years after in type 1 diabetes and at the time of diagnosis in patients with type 2. Stage patients with both. Staging should not be stage 3 only. You have to mention the level of risk attributed to albumin excretion. So stage 3 or let's say stage 4A or A2, A1, A2, or A3. So we will need, in that case, we managed to know the cardiovascular risk of those patients. We need to maximize the RAS blockade in patients. We have to use the maximally tolerated doses of RAS blockers, and the target blood pressure in those patients is less than 130/80. And preferably, if you can achieve less than 120 in patients with albuminuria and high cardiovascular risk, and in those who can't tolerate a reduction in blood pressure to less than 120. Use SGLT2 inhibitors for patients with type 2 and CKD, and in CKD even without diabetes. Initiate as long as the eGFR is above 20 and continue until dialysis. Always consider adding a GLP-1 for those patients. It's very effective in reducing cardiovascular risk, weight management, and glycemic control. You will need to layer in finerenone, either in combination with SGLT2 inhibitors initially, or you can use it later on. when you monitor the EGFR and the albumin excretion. And finally, you need to reassess your patients every 3 to 6 months for glycemia, albuminuria, blood pressure, cardiovascular risk, and you might need to readjust your medications based on the EGFR and the albumin excretion. Thank you very much. And the floor is back to you, Dr. Muhammad.
Ala, thank you so much for the very comprehensive review that we had. I have flooded questions coming over, so we'll discuss them later on. Just before we move on to the next speaker, Dr. Anas Youssef, I would just like to invite you all to our annual Congress, which is going to happen in Dubai this year between 16th to the 17th of October. And we look forward to meet you over there. Our next speaker is Dr. Anas Youssef. Dr. Anas is a consultant nephrologist. He's the head of nephrology and dialysis center. He's a consultant nephrologist at Dasman Diabetes Institute, and he's currently the president of Kuwait Nephrology Association. Dr. Anas is actually going to tackle an important aspect. There are a few questions regarding this area already, Dr. Anas, regarding updates on renal disease and type 1 diabetes. Dr. Anas, the stage is yours.
Thank you very much, Dr. Mohammed. It's a pleasure to be part of this webinar, and thank you for the organizers for inviting me. So, as you mentioned, Dr. Mohammed, I'll be speaking about the novel approach to cardiorenal disorders and diabetes. And we know that the most prevalent diabetes, the most prevalent CKD is due to type 2 diabetes, but type 1 is about 30% of the patients of type 1 will have CKD in their lifetime. 40% of type 2 will have CKD in their lifetime. So still, we have a huge number of patients that will end up on CKD regardless of their diabetes status. So if we look at the magnitude of the problem, we have increasing prevalence of diabetes worldwide. As I mentioned, mostly type 2 diabetic patients. We will have, as I mentioned, 1 in 4 type 2 diabetic patients will have CKD, and 1 in 3 of type 1 diabetes will have CKD in their lifetime. The majority of those patients with CKD, or what we call diabetic kidney disease, unfortunately will die before reaching to end-stage kidney disease. Only 10% of those patients will approach end-stage kidney disease requiring dialysis or kidney transplant, but the majority will die earlier because of the cardiovascular morbidities and mortality, so heart failure, atherosclerosis, sudden cardiac death, arrhythmias, and so on. So with the increasing prevalence of diabetes, we're going to have more and more patients with diabetic kidney disease. So the unmet needs for patients or people with type 1 diabetes is that the complications are happening in multiple organ systems, cardiovascular, so the micro or macro complications, microvascular complications are still present for people living with type 1 diabetes. And because of that, the life expectancy for these type 1 diabetic patients is reduced, and that's mostly due to cardiovascular, but more often those patients with diabetic kidney disease will have a lower life expectancy, higher mortality because of the associated CKD. So we need to tackle this problem from the beginning. Unfortunately, for type 1 diabetic patients, the majority are in younger age. So maybe in their teens, they kind of neglecting themselves or not watching their diet, maybe skipping their insulin doses. So they will end up in their late 20s, early 30s with CKD. And in Kuwait, we have a good number of type 1 diabetic patients in their early 30s on dialysis. So that's why we need to tackle the issue or the problem as early as possible. Dr. Ala mentioned screening. Screening is very important. Unfortunately, not only in our region, also worldwide, screening part is lagging in our region, whether it's due to the physicians or due to patients who are either not following up with their physicians, whether primary care, diabetology, or even nephrology, or they're just delaying the appropriate or the proper investigations to screen them for other diseases other than diabetes. If you look at the CKD risk factors worldwide, it's number one is diabetes, followed by hypertension. Then we have the other risk factors, family history of kidney disease, increasing age, obesity is very important risk factor. The long-term use of nephrotoxins, non-steroidals, smoking, all these are risk factors for CKD. And as I mentioned earlier, the prevalence is high, is about 10 to 12%, depends on which region of the world you look at. And about 50% of dialysis patients are usually type 2 diabetic patients. Now, the new approach for these patients, since the diseases are interlinked, is the cardio-kidney metabolic, CKM or CRM, if you use renal. They are interlinked. We often see patients in CKD clinic, they have a history of heart failure, they have a history, and they are diabetic as well. Similarly, heart failure patients, they can have CKD and they can have diabetes. So each disease can amplify the risk of having the other condition. And that's why we need to tackle that as early as possible to reduce the associated poor outcomes. So for the CKM, ideally, we want patients in stage 0, where they have good, healthy diet, they're exercising, they're not smoking, they have a good quality sleep, low blood pressure or within target blood pressure and blood sugar. So all these essentials in our patients to prevent the advancing stages of the CKM. And usually it starts with excess adipose tissue. This is usually the first step, which can be associated with increased glomerular filtration and leads to glomerulosclerosis and irreversible kidney damage, can lead to fatty liver, can lead to hypertension, dyslipidemia, metabolic syndrome, can lead to the increased inflammation and endothelial dysfunction and causing cardiovascular disease. All these are interlinked, and the first step usually, or the initiating step, is the excess or dysfunctional adipose tissue. So for the CKD management in the CRM or CKM syndrome, ideally, we want to reduce cardiovascular and end-stage kidney disease risk. How can we do that? Basically, we have these 4 pillars to prevent CKD progression. Dr. Ella probably mentioned them all. So in my clinic now, when I see a patient, I want to make sure that the patient is at least on 2 of these RAS inhibitors, SGLT2 inhibitors, talking about all patients. For type 1 diabetic patients, I know all studies have excluded the SGLT2 inhibitors, but now we can use the non-steroidal MRAs and GLP receptor agonists. I work in Dasman Institute. I go there once a week in the clinic, and I see type 1 patients on SGLT2 inhibitors. Of course, they are on close follow-up to prevent what we know is the diabetic ketoacidosis. So these 4 pillars, they reduce intraglomerular pressure, they provide cardio-kidney protection, they attenuate inflammation and fibrosis. And this last point, inflammation and fibrosis, is what we were lagging over the past few years. So if we look at the KDIGO, Clinical Practice Guidelines 2022, and Dr. Ala mentioned the ADA guidelines, and in 2022, they had a consensus, and mostly what they put in the KDIGO, which is the kidney disease improving global outcomes, the international nephrology guidelines they were in line with the ADA for the guidelines. So we start with the lifestyle modifications, then we have the first line drug therapies, RAS inhibitors, SGLT2 inhibitors. Of course, this was only for type 2 diabetes. And then we can add on additional drugs with evidence of heart and kidney protection, like the non-steroidal MRAs, the GLP receptor agonist. So RAS inhibitors is the cornerstone of our therapy. And in all these trials of the SGLT2 inhibitors, the non-steroidal MRAs, the GLP-1 receptor agonist, with regards to the kidney outcomes, all patients were already on the maximal tolerated dose of RAS inhibitors. So since 2000, we know that the ARBs from Renal and IDNT trial have shown good positive outcomes in reducing the composite renal endpoints that was in diabetic patients with CKD. And also, similarly, for type 1, there was the ACE trial. Now, still with these agents, we have patients that they're going to progress towards end-stage kidney disease. So speaking of the RAS inhibitors, and Dr. I mentioned that for the target blood pressure, remember it's less than 130/80, and with an encouragement to achieve less than 120/80 in those patients who can tolerate it. And this came from the AHA guidelines that was released last summer by August 2025. And their recommendations in adults with confirmed hypertension who are at increased risk for cardiovascular disease and the systolic blood pressure goal of at least less than 130/80, with encouragement to achieve systolic blood pressure less than 120 millimeter mercury. It is recommended to reduce the risk of cardiovascular events and total mortality, a class 1A, and the increased risk is defined as 10-year predicted risk for cardiovascular disease events of more than 7.5% using Prevent calculator, and this is an online calculator that you can easily access online. And where did this target come from with regards to nephrology or CKD patients? We have we know the SPRINT trial. It was a randomized control trial targeting or randomizing patient to systolic blood pressure of less than 120 versus less than 140. Over 9,000 patients with high cardiovascular risk, but no diabetic patients enrolled. About 2,600 of those 9,000 patients with CKD, mean serum creatinine of 1.4 milligram per deciliter, and mean urine albumin creatinine ratio of 80 milligram per gram, which is an A2 albuminuria. The trial was stopped early due to overall mortality benefit in strict blood pressure control arm, less than 120, which is also true among patients with CKD and in the subgroup patients more than 75 years of age. And here we can see the graph. We can see clear separation of the lines, more than 2 years with 28% relative risk reduction in all-cause mortality among the CKD patients. And this is why they put that in the KDIGO. If we can achieve the blood pressure less than 120/80, that's excellent. So my target blood pressure for CKD patients, 120/80, if the patients have CKD, proteinuria, and more than 50 years of age and can tolerate it. For elderly, frail patients, target of 150/90 seems to be appropriate. And of course, the preferred agents is RAS inhibitors, then add a diuretic, add a calcium channel blocker, and then spironolactone if we're looking for another antihypertensive agent. But we, of course, in CKD patients, we have to watch for the potassium level. Now, for the sodium glucose co-transporter, SGLT2 inhibitors, and cardiovascular trials in type 2 diabetes, they have shown a decrease in macroalbuminuria, eGFR decline, kidney failure. They've shown also cardiovascular and CKD benefits, especially in CKD patients. Multiple trials, and over the past 10 years, we have even now meta-analyses of these trials. And here we can see that the SGLT2 inhibitors reduce the risk of dialysis, transplantation, and death due to kidney disease in individuals with type 2 diabetes. We can see with regards to the end-stage kidney disease, or to progression towards dialysis and death due to kidney disease, that the SGLT2 inhibitors were favorite in reducing these outcomes. So for those agents, we start them if the eGFR is more than 20 ml per minute. Always expect a drop in the eGFR after initiation, up to 30%, similar to what we see in the RAS inhibitors. And we can monitor the creatinine 1 to 2 weeks later if this happened. And once you start the agent, continue till the patient reaches dialysis. So if you started with an eGFR of 25 and the patient eGFR dropped after a year or two, less than 20, keep the drug until they reach dialysis. And now even there are trials trying these agents in dialysis, but still the results are awaited. If the agent is stopped due to AKI, like we do with the sick day rule, make sure that you resume them once they are back to their baseline. These agents are excellent. They cause diuresis, natriuresis, glucoseuria, and uricoseuria. And we know that all the trials, the major trials, were stopped early due to a clear evidence of benefit. And from this meta-analysis in 2019, the SGLT2 inhibitors reduced the cardiovascular risk more on a background of RAS blockade. That's why we always want to start with RAS blockade. So if we compare this group here, where they were on RAS blockade, we can see this is compared to patients who were not on RAS blockade, but on SGLT2 inhibitors. We can see that significantly those patients have lower risk of cardiovascular outcomes. The SGLT2 inhibitors lower the risk of CKD progression across the spectrum of EGFR. This was a meta-analysis of 10 placebo-controlled trials of SGLT2 inhibitors. Over 70,000 participants with diabetes, CKD, or heart failure, mean age of 64, 35% were females. And from these 70,000 patients, from these 10 meta-analyses, only 3.3 patients went into CKD progression, and only 1.4% of the patients went on to reach dialysis. The SGLT2 inhibitors lowered the risk of CKD progression by 38%. This was statistically significant, irrespective of the baseline. EGFR and CKD progression was defined as doubling serum creatinine, 50% reduction in EGFR, or death from end-stage kidney disease. And the same meta-analysis showed that the same agents, SGLT2 inhibitors, lowered the risk of CKD progression across the spectrum of albuminuria. And here we can see that the reduction in the CKD progression was about 40% in those patients who were randomized to SGLT2 inhibitors. And this was shown in irrespective of the albuminuria. Of course, we see the evidence that the reduction is more in those patients with macro or severely increased albuminuria compared to the lower levels of albuminuria. Now, what about type 1? As I mentioned earlier, I see and I follow patients who are type 1 diabetic on SGLT2 inhibitors, few numbers, closely followed up. Real world data that there are some patients. This is a publication from Belgium. And we can see that about 150 patients, they put their results. We can see that the results are almost the same as in type 2 diabetes. There is a reduction in albuminuria and there is preservation of EGFR. So the feared outcome usually is genital infections, probably not in our region. I didn't see, honestly, only saw one patient who was not from the Arab world who got genital mycosis. But the thing is, the diabetic ketoacidosis is what we are fearing of. And this is in this cohort about 3.5%. But there were no events of severe hypoglycemia. And now there is this trial, sugar and salt phase 3 trial. They are randomizing type 1 patients with insulin within 1 year from diagnosis, randomizing them to sotagliflozin, which is an SGLT2 and 2 inhibitor versus placebo. And this is supposed to run for 3 years. So we will probably see the results by 2030. Now, despite the RAS blockade, SGLT2 inhibition, still we are seeing patients who progress towards end-stage kidney disease. So what were we missing? Probably the third link or the third driver of CKD progression. We tackled the hemodynamic effect with the ACE inhibitors and SGLT2 inhibitors. We lowered the metabolic pathway by the SGLT2 inhibitors and other anti-diabetic agents. But for the inflammation and fibrosis pathway, we were lacking an agent to tackle that. And until we got finerenone, which is, as we know, a novel selective non-steroidal MRA that blocks the MR overactivation, which MR overactivation will lead to fibrosis and irreversible kidney damage. So if we compare the non-steroidal versus steroidal MRAs, the spironolactone And firenone, we see that the non-steroidal are more selective, less risk of hyperkalemia, maybe not that significant effect on the blood pressure compared to spironolactone, but significantly very low sexual side effects. So in terms of gynecomastia, definitely less in the firenone group. So there is no head-to-head trial. Firenone is indicated for individuals with diabetes, heart failure, preserved ejection fraction, or moderately reduced ejection fraction. Spironolactone is indicated for HFrEF or patients with reduced ejection fraction less than 40%. I'm going to probably mention briefly about the firenone. Sorry, Dr. Ahmed, if I'm going to burn some of your slides, but there were two randomized control trials, Fidelio and Figaro. One is cardiovascular outcomes, and the other one is renal outcomes. It was randomizing firenone versus placebo, added or background of RAS inhibitors, about 13,000. Then there was a pre-specified pooled analysis, which is the Fidelity. So total of 13,000 adults with CKD and diabetes on RAS inhibitors. Potassium has to be less than 4.8, and no patients were randomized with low ejection fraction less than 40%. We can see that clear benefit of the firenone compared to the placebo or the standard of care in terms of the cardiovascular outcomes or even renal outcomes. And in terms of the reduction in the albuminuria, about 40% reduction in the albuminuria, and for the potassium, no significant increase or no clinically meaningful risks of hyperkalemia. What about type 1? Recently, we have this trial, FINE-1 trial, which is firenone in type 1 diabetes and chronic kidney disease. It was a small trial, 240 patients, mean age of 51, 66% of them males. The mean A1C is 7.8%, median urine albumin calcium ratio 574, which is an A3 albuminuria, and the mean eGFR 59. So again, these are CKD stage 3 patients. From this cohort, about 10% of the patients who were on firenone developed hyperkalemia compared to 3.3% in the placebo group. About 1.7% of the patients stopped firenone due to hyperkalemia. And here we can see the reduction in the albuminuria, which is an important surrogate marker, about 25% reduction in the albuminuria at 6 months. The trial was mainly only for 6 months. And this reduction in albuminuria of 25% tell us that on the longer run, we can reduce CKD progression. Now, what about GLP receptor agonists? Of course, many trials, they've shown decreased macroalbuminuria and eGFR decline from early to late stage CKD, and some age like liraglutide, dulaglutide, and semaglutide. Cardiovascular and CKD benefits are present in patients also with CKD. How do they work? Of course, it's multifactorial effects. Nobody probably knows how we get this benefit. And this is the exploratory kidney outcomes analysis from GLP receptor agonist cardiovascular outcome trials. These meta-analyses involving more than 40,000 participants suggested a potential kidney protective effects of GLP receptor agonists with some agents like liraglutide, dulaglutide, semaglutide, and figlinatide associated with reductions in secondary composite kidney outcomes. How do these agents benefit CKD patients? Not really well understood. The indirect effect is they improve glycemic control, they reduce blood pressure, they can reduce weight as well. The direct effect probably natriuresis, hemodynamic effects, endothelial, they might improve endothelial function and can work as an anti-inflammatory agents. The FLOW trial, as Dr. Ala mentioned earlier, came out about 2 years ago, randomizing type 2 diabetic patients with CKD to semaglutide 1 milligram once weekly. And they ran it for about 52 weeks. And the results showed a significant reduction, 24% reduction in the first composite kidney event. About 3,500 patients mean age of 66 years, 70% of them are male. The mean GFR in this trial was 47. Median urine albumin creatinine ratio was, again, 567. Mean A1C 7.8%. The trial stopped early at a median follow-up of 3.4 years with fewer renal and cardiovascular outcomes in the semaglutide group. 20 people needed to be treated for 3 years to prevent one major kidney event. Major kidney event defined as dialysis, transplant, EGFR less than 15 ml per minute, 50% reduction in EGFR, or death from renal or cardiovascular cause. So this is really a low number to treat patients, which again adds to our armamentarium in our agents to, let's say, treat or stop CKD progression. And the results were consistent across the components of the primary outcomes. Now, what about combination? Can we combine agents from the Fidelity? I'm sorry, Ahmed, I hope I'm not bending your slide, but there were some patients here who were on SGLT2 inhibitors and finerenone, and we can see that there was about 5% difference in those patients with SGLT2 inhibitors, lower albuminuria. So the confidence trial, which came out last year, randomizing patients to finerenone plus empagliflozin, 10 mg only of empagliflozin. Not going to do details, but it showed about 52% reduction in the albuminuria using both agents. So before, let's say before this trial, we were reluctant to add or to start patients on 2 agents together, fearing of this drop in the EGFR. But we can see from this trial, using SGLT2 inhibitors alone will lower the EGFR maybe by 4 ml, and adding finerenone at the same time, probably we're going to lower it by only 6 ml. So not really that significant drop on the EGFR using the combination agents. But the results is huge, additive, 52% reduction in albuminuria, which is again a very important surrogate marker. Now, this study from 2025 showing us that among individuals with diabetes, there appear to be a synergistic effect from these 4 medication classes. So we can see that the aggregated data from 2 SGLT2 inhibitor trials, 2 non-steroidal MRAs, and 8 GLP receptor agonist trials were used to estimate the relative effects of single versus combination therapies with standard of care, which is RAS inhibitors. And we can see that the combination therapies are estimated to decrease the risk of CKD progression and all-cause mortality. So here we can see for the CKD progression, using SGLT2 inhibitors, GLP receptor agonist, non-steroidal MRA, in addition to RAS inhibitors, it's additive. As we use the combination, we have lower risk of CKD progression and lower risk of all-cause mortality. So the mechanism appears to be synergistic. SGLT2 inhibitors reduce intraglomerular pressure. The non-steroidal MRA reduce fibrosis, which is a very important step. GLP receptor agonist addresses the metabolic abnormalities and endothelial stress. So reaching probably the end here, this is the KDIGO heat map. Probably Dr. Ala mentioned that earlier, and when to refer patients. So basically, as a nephrologist, I always tell my colleagues that if you feel uncomfortable seeing a patient, you think that they might benefit from a nephrologist advice, refer the patients regardless of numbers or anything. Just have this peace of mind that you did the best for the patient. And usually, if there's nothing, we'll just refer the patient back to the primary care physician. But initially, severely increased albuminuria, then you can consider referral. Of course, these patients probably are the worst, as we can see here, the red boxes. They are at very high risk of progression towards end-stage kidney disease or having cardiovascular outcomes or cardiovascular morbidity and mortality. So those patients with severely increased albuminuria are the highest risk. So probably they need special attention, and they need frequent visits, mainly to ensure that they are on these, let's say, at least 2, but ideally 4 pillars of agents to reduce their outcomes. And one important point, probably I mentioned that always don't just rely on the blood test. we need the urine test. We need to check the urine albumin-creatinine ratio. If you only rely on the blood test, probably you can miss these two groups. So if the eGFR cut point more than 60 is normal, and if you don't do the albumin-creatinine ratio, if the patient having A2 or A3, they are at moderate increased risk or high risk toward progression. So always combine the blood and the urine test and put the patient on this heat map, and sometimes help the patient to tell them that you are in CKD stage 2, A1. We don't want you to go into the A2 or A3 or lower stages of CKD in order to prevent dialysis. So the KDIGO 2024 CKD guideline recommends a holistic approach to CKD treatment and risk modification. And as Dr. Ala mentioned, we have to readdress that every 3 to 6 months to make sure that the patient on the right track. We are following the lifestyle changes, and they are on the appropriate medications for their condition, ideally the 4 pillars. So now we discussed the guidelines. Now it's time to implement. Now it's on us as physicians to apply these guidelines. So for the albuminuria, as I mentioned earlier, unfortunately, it's not that widely used. This is a simple test, probably cheap test to do to screen the patients for the albuminuria. Here we can see only probably half of the patients, despite their being diabetic, whether type 1 or type 2 in the US, that they had more than one visit with their primary care physician, but still a good number of the patients, probably half of them, did not have a urine test to assess their albuminuria. And we have similar data probably from our region. And this is another study from the US as well, looking at different time periods in terms of the prescription medications in CKD patients. Unfortunately, these are CKD patients stage 3A to 5. So they are advanced stages of CKD. And what's the most common medication prescribed for these patients? We can see that it's nonsteroidals, which is a nephrotoxic agent, followed by PPI, which also can cause acute interstitial nephritis. So, but the ARBs, ACE inhibitors, are the third mostly used agent. So we need to apply these, and this is for between before 2020. So that's why we see very less use of SGLT2 inhibitors. But hopefully we see the graph that these agents are the top prescribed agents for CKD patients. In Kuwait, we did a study looking at CKD patients over 1 year, like a cross-sectional study in 2022. And we saw that in terms of the anti-diabetic agents, SGLT2 inhibitors were only used in 25%, or let's say 26.9% of the patients. So very small number of patients, diabetic patients with CKD, and they only a quarter of them were on SGLT2 inhibitors. So we are really working hard in applying the guidelines in ensuring that patients are on these first line agents, especially when they have CKD. For the antihypertensives, the most prescribed antihypertensive is unfortunately the calcium channel blockers, followed by centrally acting agents. ACE inhibitors were third in line. So we are working in our country to change this. And of course, there is some clinical inertia that physicians will fear. If I start a CKD stage 3 patients on a RAS inhibitor, they might have hyperkalemia, the creatinine might go up, and then there is the patient and physician anxiety. But if you reassure the patient that, yes, we're going to give you this agent, the RAS inhibitor, for example, and we're going to do a creatinine and potassium after 10 to 14 days, we might see an increase in the creatinine or potassium, but this is temporary, and we're going to repeat the test after another 2 weeks, and hopefully we'll see that go towards baseline. So probably then the patient and the physician can have this mutual trust that the agent is working. And believe me that not all patients will have an increase in the creatinine. Sometimes you see patients with lower creatinine even by reducing this intraglomerular pressure. So my take-home messages: CKD in people with diabetes remain common and deadly. There's highly effective therapies now available to reduce the risk of kidney failure, cardiovascular events, and death. The 4 pillars of therapy are now a RAS blockade, an SGLT2 inhibitor, non-steroidal MRA, and semaglutide. Low CKD awareness, detection, and access to care are major barriers to receive kidney and heart, which are life-saving therapies. Effective strategies for therapeutic implementation are urgently needed to improve clinical outcomes in diabetes and CKD. With that, I conclude, and thank you very much.
Dr. Anas, thank you so much for this fantastic talk. And I think we have a few topics to discuss after the meeting. Now I would like to invite you all to attend our 10th Gulf Endocrine Review course. It's going to be online. Registration is currently open. You can actually use the QR code right now to register. And as you all know, this is a very rich program that includes international experts. So now move on to the next talk. And our next speaker is Dr. Ahmed Abdullah. Dr. Ahmed is a senior specialist in the endocrine unit in Jabal Al Ahmed Hospital. He's a graduate of the Royal College of Surgeons in Ireland, in Dublin. Ahmed, do you recognize the bridge behind me over there? And then he also completed his residency in a hospital in France. I think it's called Aix-Marseille,
Yes.
if I didn't torture the name, Ahmed. So Dr. Ahmed is going to talk about CKD, meets diabetes, unlocking the outcomes with finerenone, Carinida, is it? That's how you pronounce it?
Yeah.
So the stage is yours, Dr. Ahmed.
Thank you very much, Dr. Mohammed, for the kind introduction. And thank you for inviting me to this webinar. I'm honored to share this panel with esteemed lecturers that gave us a very nice overview of the topic. So I'll be talking about, on the same path, CKD meets diabetes, unlocking the outcomes with Carindia. So these are my disclosures, and this talk is sponsored by Bayer. So the learning objectives that I hope to achieve by the end of this talk is recognize that the cardio-renal metabolic model is a new way that we can look at diabetes, and hopefully help us look at each component at the same time to identify patients early at higher risk. I also want to talk about the unmet needs in identifying patients with high risk, and then move on with the topic of this talk, which is finerenone as the newest addition to the guideline-directed medical therapy in diabetic kidney disease, and how this came about from all the pivotal trials that we had, and also the real-world evidence. And then I will end with take-home messages. So we all know that diabetes is increasing worldwide. This is not news, but we must focus on the following point. The burden is not distributed equally. In Middle East and North Africa and Africa, we have the highest prevalence of increase in diabetes. That means we will be having the highest burden of the complications. And if we look at the Gulf region, we see about 10 to 25% prevalence of diabetes in the Gulf, which is a very challenging and frightening figure. So this means we'll be seeing more complications in the future, and more complications mean, diabetic kidney disease, retinopathy, neuropathy, heart disease, and whatnot. We know that diabetes does not come by itself. So it comes with a multitude of comorbidities and risk factors, be it oxidative stress, adiposity, dyslipidemia, systemic inflammation, and chronic kidney disease. And as one of my co-chairs and speakers said, we can look at this disease through a different lens. So once we consider that these diseases are interlinked, so one disease will affect the other, that will help us understand that these newer agents that we use will have the beneficial effect across the whole spectrum. So that explains why, for example, SGLT2s, GLP-1s have a beneficial effect across all these different organ systems because of this CRM model. So it highlights the fact that the underlying pathophysiology is quite similar. whether it's endothelial dysfunction, systemic inflammation, or excessive fibrosis leading to tissue remodeling and organ dysfunction. They all share a common pathway, such that if you have diabetes, you're more likely to get kidney disease, heart disease. If you have heart disease, you're more likely to get dysglycemia and also kidney disease. And to touch on this topic, I want to bring a case that I've changed the name to Aisha. She is a 66-year-old patient who has well-controlled type 2 diabetes. She's been living with type 2 diabetes for the past 5 years. Now she has ischemic heart disease. She underwent CABG in 2020. She's being treated by a combination pill of SGLT2 and metformin and also a DPP4 inhibitor. Now she has hypertension, hypothyroidism, and lipidemia. But if you look at her labs, I mean, you would be in agreement that her A1C is not that bad, considering the patients that we see in clinic most of the time. Her eGFR, her LDL is at target. Blood pressure, we've heard from our colleagues, the targets that we want. So I guess you would be happy seeing this patient if you miss one crucial point, and that is urinary ACR. So this patient had elevated urinary ACR, which repeated also confirmed the same level of elevation, more than 100. So what seemed to be a well-controlled patient is actually at a higher risk, because if we plot her here on the heat map, she would be in G2A2, meaning at moderate increased risk. So she has 3 times higher risk of heart attack, 4 times higher risk of cardiovascular death, and also 5 times the risk of hospitalization for heart failure. And this brings us to the point that relying only on eGFR is a late endpoint. So if you have an eGFR less than 60, by that your risk for cardiovascular mortality already is increased by 40%. But we know this is a very late sign. So you can have an elevated urinary ACR way before you have a decline in kidney function. And just by having an elevated urinary ACR above 30, your risk is increased by about 77%. So much more than waiting for your eGFR to fall below 60. And one of the unmet needs is that we're not doing enough. We're not screening these patients enough. And this is a message that I, remind myself, but also my colleagues and, in the primary care sector. It's not enough just to look at the kidney function and eGFR. We all also have to look at, urine albumin creatinine ratio. And this shows us that this is not just in our region, even the US, Netherlands, France, annual UACR assessment is, at best 66%, but most of the time it's way below what we want it to be. And the problem is, if you do not measure something, then you do not know if it's broken, then you will not be able to fix it. So that's the problem that we see with patients with type 2 diabetes. So almost half of them, or 40%, will have some form of CKD. If we do not look for them, we will not be able to treat them. Now, reduction of albuminuria, as my colleagues have said, is linked to better survival, better outcomes, and that's why the ADA recommends to at least try to achieve a 30% relative, reduction in the amount of albuminuria. And as my colleagues have explained very beautifully, the pillars of chronic kidney disease, especially if associated with type 2 diabetes, relies on these 4 pillars that we have ample amount of evidence for, and I'll be talking about finerenone for this part. So Dr. Enes has already talked about this. So the drivers of CKD usually can be seen hemodynamic problems, especially elevated intraglomerular pressure. Now that we can handle very well with the RAS blockers, with the SGLT2 inhibitors. Then you also have the metabolic damage, the endothelial dysfunction, the oxidative stress, and all of the glycemia and its nefast effects on the body. That can be handled very well with SGLT2 and GLP-1s. But the problem with inflammation, fibrosis, for such a long time, we did not have an agent that was able to counteract that. But now we do, and it's called finerenone, which is a non-steroidal MRA antagonist. And because of its mechanism of action, basically it will dampen the MR of overactivation that we see very frequently with hyperglycemia, oxidative stress, high salt load, and also with obesity. So by blocking this, by attenuating the inflammation and fibrosis, we're reducing albuminuria, and then we're protecting the end organs such as the heart and the kidney. Now, I will not go into this because it has already been mentioned, but just to highlight that finerenone is very different from the steroidal MRAs in that it's very specific and has very few off-target effects. Now, one of the effects is obviously hyperkalemia. It's one of the things that we worry about, and we know with MRA antagonists, it's a risk that we should always expect. Now, fortunately, from studies, they've shown that the risk of elevated potassium or hyperkalemia is much less than we would see with spironolactone. So on average, about a 0.2 difference. Now, ADA, in its latest guidelines, they have a class A recommendation for CKD patients. So if you have patients with CKD, albuminuria, and you want to reduce the cardiovascular events and also CKD progression, finerenone is there as a class A recommendation. But also for patients with type 2 and CKD, if you want to reduce the risk of heart failure hospitalization, and I will come to mention the studies for those. And then there's also a recommendation based on a new trial where that you could initiate simultaneously SGLT2 and finerenone without having an excessive fear of causing, hyperkalemia or EGF drop, because we have reassuring data. So where does this data come from? It comes from a number of studies. So we have about more than 13,000 patients that have been enrolled in multiple countries worldwide into one of these, hallmark studies, Fidelio or Figaro, bringing the grand total to 13,000. And just to remind ourselves, it's one of the biggest and largest trials or analyses that have patients with type 2 diabetes and CKD. So if we look at the SGLT2 trials, the Credence, DAPA, and EMPA, we're talking about 4,000 to 6,000 patients in each trial. If we look at the finerenone trials, so Figaro and Fidelio, if we combine them together, we have about 13,000 patients. So lots and lots of data. So just to remind ourselves, Fidelio was mostly focused on the primary endpoint or the composite endpoint of kidney outcomes, and then the secondary were the heart disease. Figaro, it was the other way around. The primary outcome was looking at the composite endpoint of cardiovascular disease, death, non-fatal MI, and stroke, and the secondary was looking at kidney outcomes. And just one slide, just to remind ourselves of the Figaro and Fidelio. So Fidelio showed that the primary outcome was achieved with a reduction of 18% for CKD, and likewise Figaro showed a reduction in the primary outcome, and that was shown by a 13% reduction in risk of cardiovascular mortality and morbidity. And likewise, we see the same for the secondary outcomes. So both trials had very good outcomes. Now, if we add them together, we will have more data and a more wide capture of patients, because Fidelio had most patients with A3 and some of the patients we would see in the G3 and G3B. Whereas Figaro had, had a more broader spectrum of a range of EGFRs. And if you combine them together, if you have a pooled analysis, you have a bigger cohort, a more reflection of the patient population that we see every day in our clinics. And this is also highlighted in this slide here. And so in the Fidelity, when you have all these 13,000 patients together, about 40% of the patients were like Aisha, my patient in the clinic. So they had albuminuric CKD with an EGFR above 60. In other words, patients that would be missed if you do not look at the urine ACR. So this is explained here. So 40% of the patients had a GFR above 60, but look at the median urinary ACR, about 32% had what we would call A1, and then the majority would be categorized as A3. So what did Fidelity show? Well, not surprisingly, it showed the same relative risk reduction in both cardiovascular and kidney outcomes. So if we look at the kidney outcomes, 23% relative risk reduction in progression of CKD with a 20% risk reduction in end-stage kidney disease. And likewise, for the cardiovascular morbidity and mortality, we see a reduction of 14%. And if we talk about heart failure, a reduction of 22%. What about the UACR? That was decreased by about a third. So this is a 32 significant percent, and it mirrors what the ADA was saying about try to achieve at least a 30% reduction in the UACR. The slide was shown previously as well, so we could see how there's a nice drop in the urinary ACR that is extended and maintained throughout the study trial. So there is no difference in terms of the benefit that we've seen from finerenone, regardless of the background use of SGLT2 or if there was GLP-1, and there was no big difference or any effect on glycemia. What about adverse events? Now, the thing that we worry about the most, obviously, is potassium. But this is reassuring to us that the mean difference was about 0.2, and only 1.7% had hyperkalemia that was significant enough, leading to permanent discontinuation. Because we know that you could stop and hold the treatment and then reinitiate with a lower dose once you have your potassium less than 5. Now, if you talk about any percentage of hyperkalemia, obviously you will have a higher percentage in this group compared to placebo. And then in terms of, A1C, we said there's no difference. Gynecomastia, there's no difference whatsoever. Small, a drop in your systolic blood pressure, which is quite often welcomed. And if you look at the slope of EGFR, and we've seen this, and we have experience with this with RAS blockers, with SGLT2, that you might, and you actually want to see a drop in the beginning, because that tells you that the molecule is working. That tells you that the molecule is reducing the intraglomerular pressure. But in the long run, the patient benefits because the slope will be less steep than those who are on placebo. So there is a momentarily drop, but in the long run, you win the race. And the benefit that we see with finerenone in these patients in the Fidelity, pooled analysis was regardless of the background SGLT2 use. And that brings the question of what if we add these together? And I will come to talk about this in the confidence trial. So what about real world data? So we talked about, the pivot industry-based trials. But let's look at some data from, insurance claims and US databases, because these are huge. And we could look at thousands of patients just through one database. So this is an observational, retrospective, longitudinal, single-arm cohort study in the US. And they had patients with CKD and type 2 diabetes. And the outcome that they wanted to look at with finerenone was basically what is the incidence rate of hyperkalemia and how does UACR change over time? Is it the same as we see in the industry-based or funded trials, or is it different? So just to go very briefly over this, mostly it was a white population, obviously, and the mean age was 70, and the majority were male patients. Now, these are patients who have the CKM disease model. So they have type 2 diabetes, they have hypertension, chronic, coronary artery disease, and also the different complications of diabetes. The majority of the patients were in stage 3, so CKD stage 3, and they were split almost equally between A2 and A3 in terms of albuminuria. So 50% of them were already having RAS blockade, and finerenone was added to it. About 38% had finerenone added to an SGLT2, 25% had already background GLP-1 receptor agonists. Now, in terms of hyperkalemia, this is what they found. So among the patients, among the 15,000 or about 16,000 patients that initiated finerenone, we had a 1.3% that had hyperkalemia during the follow-up. And we would say hyperkalemia, that is, the significant one that would persist. But what about discontinuation, hospitalization? That was a very small minority, 0.04%. So reassuring data from real world evidence. What about UACR? Well, we see numbers exceeding what we would have expected. We see about a 39%, almost 40% reduction in UACR compared to baseline. Now, I will just switch to my second presentation. I'm sorry, I had to split them in two. So as we said, there's inertia in initiating these pillars of GDMT, so guideline-directed medical therapy. And one of the questions we ask ourselves is, do I start this agent first, and do I call the patient 2 months, 3 months later to add the second agent? Can I try them together? So we've seen this with, heart failure medications. We've seen this approach with even in diabetes when you initiate dual or triple medications at once. So is there a benefit of combining therapies at the same start? And one of the questions was about SGLT2. And we've seen that from real world evidence, combining these two agents together, you will have a synergistic and additive effect in reducing the UACR. But how can we prove this? It's safe to reassure ourselves and the patients. This was the whole premises of the confidence trial. So as Dr. Anas has shown us, this is a trial with the sole purpose of showing us that combining these agents, so a finerenone plus an SGLT2 together at the same time, is going to be beneficial and safe. So this is a randomized double-blind, double-dummy, multi-center, 3-arm parallel group phase 2 study where you had patients either on finerenone plus empagliflozin 10 milligram or finerenone plus placebo, or just the empagliflozin plus placebo. And they were followed for about 6 months, but they were also followed for a washout period, 30 days post washout. And we had about 800 patients in total. So the primary endpoint was to look at the relative change in urinary ACR from baseline to 6 months for the combination group versus SGLT2 itself, and then the combination group versus finerenone by itself. Now, obviously, you want to look at secondary endpoints, which are secondary efficacy, but more importantly, you want to look at safety outcomes, so acute kidney injury, hyperkalemia, and sustained loss of eGFR. So this is, from the patient population, what we have is mostly A2, A3 patients in terms of albuminuria, and the eGFR was ranging from 30 to around 90 ml. So about 3/4 were female, 3/4 were male, 25% only female. The mean age was 66, and we had a median UACR in the A3 category, so more than 300. The mean serum potassium was 4.5, and you can see that the race was, more equally distributed amongst white, Asians, and Black African Americans. And you had the majority of the patients already on ACE or ARB blockade. What did we see? So at 6 months, we saw the group that had the combination therapy, a 52% reduction in the UACR. And we see this, starting very early and being sustained. And this gray area here shows that once you stop the medication, it goes back up. And I think this is a very crucial point that we should highlight to our patients, because I've seen this from some patients saying, great, now I have no Zulal, no albuminuria. Can I stop the medication? And you tell them no, because if you stop it, you go back to 0.0. Your albumin creatinine ratio will go back up to the abnormal result. So this shows you that you need chronic persistent treatment. And this graph shows you that the result is quite early. We used to think, it has to be around 3 months that you see the effect, but you could see at least a 30% reduction even early as 14 days. Now, what about discontinuation, treatment adverse events? Now, less than 5% had adverse events that led to discontinuation. So this is reassuring data for us. Acute kidney injury was very minimal, and also hypotension events also very minimal as well. Now, as we all know, from anything that will alter the hemodynamics of the glomeruli, you will see a drop in the eGFR. And you know this is not kidney damage, you know this is not structural damage by one thing only. And what is that? Here. Once you stop the medication, 30 days off, you have a washout period, boom, it goes back to where it was. So this is not acute kidney injury. This is not damage to the organelles. This is simply a hemodynamic effect. And we've seen this with SGLT2s, and we've seen this with RAS blockade. And so this for us is not alarming. In terms of blood pressure, we see an additive combined effects of both your SGLT2 and finerenone. So you could see a mean systolic blood pressure change of about -7.4 in the combination group compared to -3 in finerenone and -3.7 in empagliflozin. And I don't know about your patients. For my patients, most of the time, it's something that we want, because most of the time the patients are not optimally controlled in terms of the blood pressure. What about hyperkalemia? Well, it's actually better to give a combination, because you have a reduced risk of having hyperkalemia. So here in the purple is your empagliflozin, the percentage of people having hyperkalemia, 3.8. In blue is your finerenone, 11.4%. In the combination group, it's 9.3. But then again, this is all and any hyperkalemia. What about those that lead to discontinuation? Very minimal. So just to highlight the safety of a combination approach, initiating both SGLT2 and finerenone together, the rate of hyperkalemia is actually in your favor. So if you're worried about, I would argue, if you're worried about initiating finerenone and having hyperkalemia, adding an SGLT2 with it at the same time decreases your risk. So that was the overall takeaway message from the confidence trial, that simultaneous initiation is both effective, leading to early clinical meaningful reduction of the UACR, but it's also well tolerated and very safe. Now, we've talked about the trials, we've talked about everything. Now, what about the practical point? How do you initiate this therapy? Now, you have to know about the contraindications. So the contraindications are if you have any hypersensitivity to this, pregnancy obviously is not within the allowed criteria, and in some labeling countries, if you have Addison's disease, or any form of deficiency in your aldosterone pathway. So you want to start with doing two things: measuring your eGFR and your potassium. So if your potassium is less than 5, you look at your eGFR. If it is between 25 and 60, you start with the starting dose of 10 milligram. If it's above 60, you could go all ahead and start with a 20. Now, if it's below 25, you do not initiate finerenone. Now, as we said, you can expect a drop in the eGFR, and you could continue up to an eGFR of 15. If your potassium is above 5, obviously you will not initiate. And you could consider, potassium binders to have your potassium decrease so that you could initiate your therapy later on. You should always check your serum potassium 1 month later, along with your eGFR. So if your eGFR decline is less than 30% and your serum potassium is less than 4.8 or equal to it, then you can increase your dose from 10 to 20, or even maintain it if you're already on 20. And as we said, you could maintain it as long as your eGFR is above 15. Now, what if your potassium 1 month later is between 4.8 and 5.5? Then you maintain the same current dose. You do not increase. If you're on 20, you stay on 20. If you're on 10, you stay on 10. Now, if it's above 5.5, that's when you want to withhold treatment, and that's when you want to restart, only when your serum potassium is once again less than 5. Now, do you check every month until the rest of the patient's life? Obviously, no. Once you have the 1 month, green light, then you could do every 3 months, every 4 months, you check your potassium. Now, I would like to end with some take-home messages. So, number one, we should look at type 2 diabetes as part of this cardio-renal metabolic model. By looking at it this way, and vice versa. So if you have a patient with heart failure, you should always ask yourself, am I missing dysglycemia? Am I missing kidney disease? If you have kidney disease, am I missing dysglycemia, prediabetes, or heart failure, even HFpEF? So always look at it this way. Urinary ACR is largely underutilized in practice, and this is leading to missed opportunities to help patients. Finerenone is a novel pillar of the guideline-directed medical therapy for type 2 diabetes and CKD. It is safe, it's easy to use, it reduces CVD and CKD progression in type 2 diabetes CKD. You could use it as a combination therapy from the start with your SGLT2, as we have evidence that's safe. And then just please break the inertia. And I say this to my colleagues in endocrinology. I see some, reluctance saying that, refer to nephrology. It's their drug. It's their domain. We don't do this with ACE or ARB when we have microalbuminuria. We start ourselves a small dose of ARB or ACE. So the same principle should apply. You don't need to refer just to start this treatment. It's not just a kidney disease molecule. You can use it to reduce the risk of your patients. And with that, I end my talk and thank you for listening.
Dr. Ahmed, thank you so much for a very nice, and I think it's kind of covering most of the topics you actually asked around. However, there has been a discussion about the albumin-creatinine ratio and the fact that we are not good at measuring it. And the question here that comes from Dr. Ala Shirbini, he said, well, that's great. We understand the importance of urine albumin-creatinine ratio, but he said, does the urine sample need to be given first thing in the morning? And can the patient, and he went over to say, if the patient collect the sample early in the morning at home and he brought it in, how long does the sample stays valid for analysis? So can I bring in Dr. Anas, please? Do you want to take this question?
Yeah, so
does it have to be early in the morning?
All guidelines, or let's say all recommendations, first void sample is ideal. But as I mentioned, now we're lacking the screening. So if the patient will not do it in the morning, will do it at night, go ahead. We just need the samples. We need to monitor the albuminuria and probably do it the same time every time. The first void is a concentrated sample. So it's ideal, but if it cannot be done at that time, do it at any time of the day. But the follow-up should be also around the same time of the day. For the second part, to be honest, I'm not sure. We have to ask the lab how long the sample can be outside.
Can be processed. Great. Now, Dr. Ala, there is a question over to you which says, for patients with chronic kidney disease, diabetic kidney disease, is it necessarily that retinopathy appears before nephropathy, or they are not interlinked?
Well, there is a good correlation between diabetic nephropathy and retinopathy. Usually retinopathy occurs earlier, and that's why it's a marker of diabetic nephropathy. So whenever I examine a patient and I find retinopathy, then it's likely that this patient will have nephropathy as well. So we need to check for any patient with retinopathy the UACR and creatinine. This is one important point. The second is that patients with nephropathy, they usually get worsening of retinopathy with the development of nephropathy because of associated hypertension and worsening likely of glycemia. So they are interrelated. Usually retinopathy occurs earlier, but it's a marker of presence of nephropathy as well.
I think the reason behind the question is you raised the differentiation between albuminuric and non-albuminuric kidney disease, and it seems you're pointing towards that non-albuminuric seems to be a different disease with maybe a macrovascular manifestation of the disease, and hence what you probably mentioned over there, you don't necessarily have to have a retinopathy in this type of diseases. So you can have a decline in EGFR without actually increase in albumin creatinine ratio.
Yes, as I mentioned earlier, Dr. Muhammad, that the non-albuminuric is a macroangiopathy rather than microangiopathy. So retinopathy and diabetic nephropathy with albuminuria are microangiopathic, while non-albuminuric is a macroangiopathy. So the diabetic nephropathy is related to retinopathy, but the non-albuminuric is not.
There are a myriad of questions all related to the drop in the eGFR with all the agents currently. And I think all of you have showed that in your presentations. And a few of the questions already mentioned, should you worry about that? And I think Dr. Ahmed said in the presentation, not. However, there are questions here. Should we expect that the eGFR is going to come back to baseline with the use of any of these agents, or should we always expect that the eGFR will continue to decline? Dr. Ahmed, if I get you to comment on this.
Yeah, so from the studies, we know that this decline is momentarily. There's no further decline. I mean, obviously, all of us will have some degree of decline, as you know, as we age, whether we have diabetes or not. It's more accelerated in patients with diabetes. But those who have these treatments, they will have a less steep decline. So the idea of having it go back to baseline, I think it's ingrained in our minds because we always think about acute kidney injury and, after the washout of the toxic medication, nephrotoxic medication, then it goes back to normal. But we should shift the mentality of our thinking with relation to these medications. So this is not a damage to the kidney, and you shouldn't be expecting it and to go back to baseline unless you stop the medication, which was shown from the washout trials. When you stop the medication, it goes back exactly to normal.
Dr. Anas, you want to comment on this?
Yeah, so it's basically a hemodynamic effect, like the RAS inhibitor. So the drop might happen, not in all patients. As I mentioned, some patients remain the same or even go lower. So when I see patients with a rise, probably repeat the test after 2 weeks, might be that they will go back to their baseline. But it's a hemodynamic effect. If you stop the drug, the creatinine will go back to where it was.
So another question related over here to SGLT2 inhibitors, and there are a few questions related to the adverse events of SGLT2 inhibitors and how you tackle that. So one of the questions are all related to what do you do, Dr. Ala, if you have a patient with chronic kidney disease, you're giving SGLT2 inhibitors and they're having adverse event, either recurrent urinary tract infection, that's one question, or in elderly patients where they have urinary urgency or incontinence. Are there anything you can do in order to improve their tolerance to these medications?
Well, that's a good question. With regard to the recurrent urinary tract infections, it has been shown in studies that the prevalence of genital infections is basically very low. And if the patient had a urinary tract infection or a genital infection, we usually treat the infection, restart the SGLT2 inhibitors again. Unless it is a recurrent urinary tract infection, then in that case, we might withdraw the SGLT2 inhibitors. With regard to the frequency in urination, there are multiple factors that might be associated with increased frequency, especially in elderly patients. They might be hypertensive or having heart failure. They are on diuretics at the same time. So those people would try either to withdraw the diuretics and keep the SGLT2 inhibitors, given the benefits associated with the SGLT2 inhibitors. So we try to look at other factors that increase the frequency. And usually, from all studies, that the total amount of urine excess passed per day is around 400 ml. And that's one extra void. So it's unlikely to be a trouble unless the patient had prostatic hypertrophy, where they have an increased residual volume in the bladder, and that will increase the frequency.
That's perfect. Dr. Anas, there are repeated questions regarding ACE and ARBs. And I can summarize them in two aspects. One of them is saying, is it a must that the patients be on ACE and ARBs before you start them on SGLT2 inhibitors or finerenone? And is it a must that they are, if that's the case, should they be on a maximum dose, or should they be on what's the dose basically? Should they be, you have to maximize the dose first, or you can start it without on a smaller dose?
Right, great question. So all the trials have shown that the patients, these agents were added to RAS inhibitors. Now, if you have a patient with already low blood pressure, 100/60, so basically, and with albuminuria or proteinuria, so you cannot add a RAS inhibitor. Probably the blood pressure will go lower, and they will have postural hypotension and dizziness. So in these patients, I can start SGLT2 inhibitors or Renal for the proteinuria. But ideally, they should be on that. And again, the trial showed maximal tolerated therapy. There was a trial, I think a Chinese one, showing that in those patients who achieved the maximal tolerated therapy, the outcomes were better. And I think I showed a meta-analysis that on a background of RAS blockade, the outcomes also were better compared to no RAS blockade.
That's perfect. Dr. Ahmed, there are a few questions regarding benefits in patients with no albuminuria and decline in EGFR, but there's a specific question here to say, if you have a patient with reduced EGFR but normal albuminuria, that's the phenotype that Dr. Ala mentioned too, can you still use finerenone in this group of patients, or they have to have macroalbuminuria?
So, the approval, the FDA approval was for CKD with albuminuria. And the trial, if you look at the trials that have in all patients, they had to have albuminuria, whether it's A2 or A3.
Same question going to you, Dr. Ala, as well, because that's the question about albuminuria. Will they benefit if you give with the decline EGFR from SGLT2 inhibitors if they don't have albuminuria?
Yes, I have mentioned that in the EMPA kidney study, there were around 20% of patients who didn't have albuminuria, and they did show benefits with regard to renal and cardiovascular outcomes.
Okay, so you will still recommend it in this
Yes.
regard, even if there's no albuminuria.
Yeah.
So if I can comment here on the same line,
Please.
Ideally, these agents should start as early as possible. So don't wait till the patient have progressing CKD or low EGFR. The earlier you start, the better. And I think I showed the meta-analysis. So the combination of these agents is good for kidneys and for cardiovascular outcomes. So start them as early as possible. Don't wait till it's too late. Screen for albuminuria, because we don't. And once we see the albuminuria in the patient, probably they lost 50 to 70% of their nephron mass. So start them as early as possible.
That brings me to there is one question related to this. I'll come back to it with Dr. Alat, but Dr. Alat, there is a specific question about what is being mentioned of how do you deal with patients, diabetes, with chronic kidney disease, hypertensive, and pregnancy. Is there anything you can do to protect the kidneys at that point in time? Dr. Ala has alluded to the death medications cannot be used that we use for kidney protection, but is there anything else they can do during pregnancy?
I mean, none of these agents being studied in pregnancy, I believe. So we have to control diabetes with insulin probably, and blood pressure with the calcium channel blockers or methyl-dopa. But unfortunately, we can't use any of the other medications. That's
Other agents, yeah. I totally agree. Ala, you want to comment?
No, I just wanted to say we cannot use these medications. And in patients with pregnant ladies, then it's important to get a good glycemic and blood pressure control to protect the kidney. So it's basically glycemic and blood pressure control.
Blood pressure control. There is one question regarding the escalation from their medications, going from SGLT2, adding GLP-1, and then adding finerenone to the agents. And the question is, what parameters do you use to escalate the doses, and at what point in time you decide to go to the next level? Dr. Ahmed, you want to comment on that? So they said the algorithm is talking about escalation, but it's saying when to escalate.
So my point of view, I think it's best to try and hit them all, because we know that these different agents, having a small dose of each would probably benefit because remember the slide that shows the hemodynamic effects, the metabolic effects, and the fibrosis effects. So if you think about the mentality of just using one agent and maximizing and then waiting if your UACR is still high, then adding the second and third, you're probably missing different points of pathophysiology. So I would rather favor one uses all different molecules, so a GLP-1, a RAS blocker, SGLT2, and a non-steroidal MA, which is finerenone, to tackle these different pathophysiological points.
Aspects.
Yeah.
Great. Dr. Ala, you have in your guidelines, what did you decide on how to escalate in UAE?
Yes, basically, we recommend a combination therapy in high risk patients. We start with SGLT2, GLP-1, and finerenone if there is still albuminuria. And we do suggest that with the after the publication of the confidence trial, that we consider combination therapy even with finerenone at earlier stages at a higher EGFR, because when you give a combination, the dip in EGFR is a bit higher. So you don't go for example, 30, and you say, I'd like to start a combination of SGLT2 and finerenone, then you dip your patient into stage 4 CKD. So you start earlier at 60 and above 45, you start combination therapy, but SGLT2 is a must combination or sequential.
Dr. Anas, your input?
I mean, for combination after the confidence trial, so it's easier if the patient already on RAS inhibitor. You're going to add both empagliflozin with finerenone, and if they are diabetic or have cardiovascular disease, you can add GLP receptor agonist. Usually with these agents, the GLP receptor agonist, I don't see a drop in EGFR. Maybe it's patient-related factors like they're not drinking enough water, but the drug itself doesn't cause a drop in EGFR. So you can add it at any time.
Great. I think we're going to take this our last question. It's amazing everybody is still around for the discussions. But it's getting late in certain countries. So we'll take this the last question, because I'm asking you here to speculate, because there is a huge interest in looking at, apart from one study, which is finerenone, how about the other agents, which is GLP-1 receptor agonist and SGLT2 inhibitors in people with type 1 diabetes? I know we're still waiting for the evidence to have a strong evidence to use these agents. But currently, and I will go around one by one, do you, in your practice, use these agents? And do you have any precautions when you're using the agents? So I'll start with you, Dr. Anas.
So
in type 1 diabetes,
SGLT2 inhibitors, I refer them to the diabetologist because they need a close follow-up.
Close follow-up.
As I mentioned, I see patients and they are on it and no issues. GLP receptor agonist, to be honest, I don't see a point of harm. I know there is no evidence, but I don't think there's a problem starting these agents. And still, I see patients on these agents as well.
With type 1 and kidney disease. Dr. Ala?
Let me start with the SGLT2 inhibitors. We recently started having the sotagliflozin, but previously I used to, in patients with type 1 diabetes, to use dapagliflozin 5 milligram as earlier recommended by the European.
EMA.
Yes, and basically I choose a patient who is educated and who is willing to do ketone testing at home. So this is for the SGLT2. For the GLP-1, I use it actually more frequent than SGLT2 in type 1, especially if they are obese, if they're planned for renal transplant as well, and they're obese. So it actually reduces weight, reduces insulin requirement, and basically prepare them for the transplant procedure.
I'll take Dr. Ahmed input. Do you see these type of patients, and any precautions do you take?
So I agree with Dr. Ala. I'm not very keen on the SGLT2 inhibitors in patients with type 1 diabetes, especially if I'm not confident with the way they handle their diabetes. Now, in the future, when we have these continuous glucose and ketone monitors, maybe I might change my viewpoint. But since we have another agent such as finerenone, which was studied in a trial, FINE-1, I am more inclined to use that. And for GLP-1s, we have more and more reassuring evidence of the safety and its use in patients with type 1 diabetes, especially in the context of obesity. And so I'm more confident to use GLP-1s in those patients.
And the only thing I will add, if I may, is the only worry about these agents is diabetic ketoacidosis. And the worry, even with GLP-1 receptor agonists, is diabetic ketoacidosis because it can induce vomiting, and some people will stop insulin, stop eating with that. And in people with chronic kidney disease, that is still a worry because it can actually, they're more likely to have nausea and vomiting. And I think proper education and monitoring is really critical. I'm a big fan of DAP 5 milligrams when it used to be available, but it's not commercially viable, so they took it out the market. But they are hopefully will get more evidence with sotagliflozin in the future. Gentlemen, I would like to thank you all for this very wonderful seminar and very nice talks indeed. And I can tell you everybody is still around in the audience. So I would like to thank the audience for their participation. I would like to thank them all for staying late at night with us. So tomorrow we actually have another webinar about management of dyslipidemia. So you can register for tomorrow. The registration code is in front of you. It's going to be another interesting webinar discussing dyslipidemia from different aspects. And tomorrow I'll be speaker. I'm not going to be a chair of the session. We also value your feedback. So please tell us about the sessions. What do you want to see in the future webinars? We're working hard to make sure that these webinars are actually happening quite frequently in order to meet the education needs and updates for the whole Gulf region. So, gentlemen, you agree with me that was a very, very wonderful session. I would like to thank you all for that, and hopefully we'll see you all soon in another webinar. Thank you.